Hi, this is your iBook for the musculoskeletal disorders in children. I wanted to go ahead and narrate this one so that we had plenty of, if you had questions on it, you had plenty of time to ask me about them so that we can still get started on respiratory next week. So first, I just wanted to point out that at the end of the material in Chapter 38, there is a slide that has the teaching so that you can make sure that you can educate your patients. One of the reasons that I do that is if you can explain something in lay terminology, that means that you know it very well. Okay, so that's one of the reasons I always have teach these people about patho slide in here. So as you'll notice in your iBook, you do have the answers to these. Okay, so I encourage you to go ahead and try to answer them to yourself before you actually look at the answers. And some of these will appear on your exam, not exactly the same, but knowing these will help you on your exam. The case studies are the same way. There are answers in your iBook. I am going to very quickly talk about the alterations of musculoskeletal functions that we went over in class, highlighting for you some of the things that I think people had trouble with in the future or in the past. Okay, so we talked about fractures. Remember that your complete or incomplete and closed and open fractures, we talked about those. We used to call those compound and simple fractures. So a compound fracture broke the skin and a simple fracture did not. We now call them closed or open. We talked about a few special kinds of fractures, like your spiral fracture, which is usually indicative of child abuse, but could also be a fracture. Somebody talked about somebody doing a ballet move that had done that. Somebody else's arm was twisted from like the leash of a dog. So it is possible to have a fracture, to have a spiral fracture when it's not child abuse. It's just what we in general saw. So that's why it's, especially in a child, it is indicative of somebody that you might want to take a look at. We talked about the stages of bone repair. So you need to understand these 4 stages, or these 5 stages here, I'm sorry. So know the terms, okay, and understand what happens there. We talked about the symptoms. Ooh, there's our open fracture. Look at that. Yeah, that's gross. And then we talked about both external and internal fixation. Okay, this one is your external and this one is your internal. Okay, remember that the reduction is actually putting the bone back in place. So an open reduction would be if we have to use surgery. Closed reduction is if we just manipulate it back in place. We talked about dislocation and subluxation. So remember that both of these are also painful, okay? And with both dislocation and subluxation, you're going to have limited movement, you're going to have pain, you're going to have possibly some swelling. It's sometimes more painful than an actual fracture, depending on the extent of the fracture that you're talking about. So you can have subluxation of your shoulder, you can have subluxation of the discs. Okay, so it doesn't. Your shoulder can either be dislocated or subluxated. We also talked about support structure injuries, strains and sprains and avulsions. Okay, remember that the avulsion is that complete separation from where the tendon or ligament is supposed to attach. Okay, so and then we talked about strains and sprains, and then we talked about muscle strains. Whoops, I skipped a couple slides there. We didn't talk about muscle strains yet. First, we talked about tendinopathy and bursitis. Remember, itis versus osis. Okay, bursitis is inflammation of a bursa. We'll sometimes see that bursitis in a shoulder. Epicondylitis is like tennis elbow, and that's an inflammation of a tendon where it attaches to the bone. Okay. Here's your, these are for compartment syndrome and your crush injuries, which is out of place, and I didn't move it again. Then we talked about muscle strains. Remember, we've got 3 grades of muscle strain, grade 1, 2, and 3. Grade 1 is what we say is pulling a muscle, okay? Grade 2 muscle strains, we've actually torn part of it, okay? And then finally, grade 3, we've torn that muscle completely in half, okay? So that is going to be a lot more painful, okay? Remember, with grade 2, we have weakness and pain. Grade 1 is just pain. Grade 2 is weakness and pain. And grade 3, we have weakness, pain, and loss of function at this point, because when those muscle fibers try to contract, they're not held together anymore. Let's see. Oh, I actually took this out of your old iBook. This was an old one. Okay, rhabdo. So when we go back to this this concept map here, you can see where you've got your compartment syndrome and your crush syndrome. And the crush syndromes can lead to rhabdo, as can compartment syndrome if not treated. So remember, with rhabdo, this is myoglobinuria, okay? So this is where we have that cola-colored urine from the myoglobin. Remember that your muscles release myoglobin when they're injured. And if you have a severe muscle injury, which can come from crush syndrome or compartment syndrome, you can get rhabdo, because all of the myoglobin that is released from those damaged muscle cells clog up your kidneys. And when they clog up your kidneys, they start releasing the myoglobin into your urine. And I told you the story about the guy who he was like working out, like lifting a bunch of weights and all that, and then decided to hydrate with beer at the pool. So yeah, he had this really, really dark urine, and that's that cola-colored urine that we're talking about. It looks different than blood in the urine. That would be hematuria. So when you're studying that in assessment and fundamentals. Look, there's that again. All right, osteoporosis. We talked about this. We know this is porous bone. Okay, the bone the minerals are leached out. Okay, so we have reduced bone density. We check this via a bone density scan or a DEXA scan. Typically, the bone itself looks the same on the outside, but on the inside, remember that it loses its structure. So our compact bone looks more like spongy bone, and our spongy bone is just, it's practically completely disintegrated. So we talked about risk factors for osteoporosis, including excess intake of caffeine, alcohol, nicotine. Okay, this lady here has osteoporosis. She also has a problem with her spine. She's got a lot of kyphosis there, and that does go hand in hand with that. Decreased levels of estrogen, sedentary lifestyle, all of those things are potential causes of osteoporosis. You do not need to know these classifications. Like I said, just remember that it's typically age-related. And then I wanted to show you this, where we see the net bone loss in men versus women. You can see how much more significant it is in women. Osteomalacia or rickets is the deficiency of vitamin D, which lowers the amount of calcium we can absorb from the intestines, and so it doesn't mineralize our bones, and so they are soft. So the calcification never occurs. Manifestations of this include pain, pathologic fractures, collapsed vertebrae, and then malformed bones. Not as bad as Paget's disease, but they will sometimes curve a little bit, and you can see that in this one here. You can see where this bone here is malformed. Okay. Remember, in adults we call it osteomalacia, and kids we call it rickets. Same thing. Treatment, vitamin D. Ayers-Paget disease, we talked about this. We don't know why it happens. We do know that it causes skull malformation, excessive curvature of the bones. It causes deafness, causes atrophy of the optic nerve, and thus blindness. So this is something that does not have a very long life expectancy. A lot of this is because of the brain compression. Okay. Osteomyelitis. This is our infection of the bone. It's usually from a staph infection. Most common cause is an open wound, but it can also be from septicemia, which we know is a bloodborne infection. Okay, so anytime somebody has sepsis, which is an infection, if their bloodstream if the bacteria is in their bloodstream, there is a potential for osteomyelitis, which is why we are very careful to treat septicemia very quickly and thoroughly. The other way is with an open wound, and that includes, surgical sites. Okay, so if you get for example, a septic knee replacement, you get osteomyelitis. Excuse me. Manifestations of this are both acute and chronic inflammation, depending on whether it's acute or chronic osteomyelitis. Fever, pain, necrotic bone. Okay, remember this bone here was necrotic. They've probably scraped it out from surgery. Okay, it's very difficult to treat. We're talking about probably like 6 weeks of antibiotics, maybe more. We do give hyperbaric oxygen therapy because it increases the circulation. Okay, we can actually have pus draining out of the bone and out onto the skin with that. All right, and then we talked about inflammatory versus non-inflammatory joint disease. Remember that this inflammatory joint disease is when you have systemic signs and symptoms. Okay, and the non-inflammatory joint disease, you typically don't have systemic signs and symptoms. So that would be like osteoarthritis. Okay. The other thing with rheumatoid versus osteoarthritis, or our inflammatory versus non-inflammatory, is that our inflammatory joint diseases have synovial membrane inflammation, and that we can check by doing an analysis of the synovial fluid as well. So I don't know if I mentioned that in class, but that's just another way we can differentiate between rheumatoid and osteoarthritis. So we know osteoarthritis is that degenerative joint disease. Risk factors here, number one is just age. It's idiopathic, meaning we don't really know why some people get it. We do know that there are some things that are risk factors. Okay, joint trauma, long-term mechanical stress, and so we talked about sports players there. Endocrine disorders, hyperparathyroidism makes you at higher risk for it. Drugs and obesity will all put you at higher risk for osteoarthritis. Characteristics here. So we have our lovely picture here of the gentleman in the adult diaper, and he's showing you his knees. Okay, manifestations of osteoarthritis include our pain, okay, and that usually worsens with activity. Stiffness that actually diminishes with activity. Enlargement of the joints, just like this guy's knees. Tenderness, limited motion, and then deformities. Remember, our deformities aren't as bad in osteoarthritis as they are in rheumatoid arthritis. Here's the Bouchard and Hebertine nodes, and you don't need to know these, but one of the things that I was, that I wanted to point out is that you do get the nodules on your hands, these little nodes, with osteoarthritis, and you get them as well with rheumatoid, and just understand that they are different. So rheumatoid arthritis is an autoimmune disease. It is an inflammatory disease with similar symptoms, except that they also have a positive rheumatoid factor, or RF test, and the synovial fluid, that joint fluid, has an inflammatory exudate. So we do have synovial membrane inflammation. We're not exactly sure of all of the things that happen in rheumatoid arthritis, which is why I don't expect you to know this, okay? But we do know that it's an autoimmune thing. Manifestations, typically this happens with adults. However, it can also happen with children. We call that juvenile idiopathic arthritis, and I'll get into that with the rest at the end of the narration when I'm talking about children. But the joints, we tend to get this ulnar drift, which is shown there, and also the subcutaneous nodules that you'll get, okay? But notice that you have systemic manifestations of inflammation here. You have fever, fatigue, weakness, generalized aching and stiffness. This is a bilateral joint disease, okay? So we will see 4 or more of the following, including of the hands, the stiffness in the morning that lasts at least an hour. That stiffness is not relieved with activity. See, that's the difference between our osteo and our rheumatoid arthritis. Remember that osteoarthritis, once they move around and exercise a little bit, that stiffness does go away. We'll have that elevated RF factor again, typically. Arthritis of the hands, I think I mentioned that, and then the rheumatoid nodules. Ankylosing spondylitis. This is again an immune disease, and we're not exactly sure how this happens. We know it is an inflammatory autoimmune disease, and we know that it starts in the sacroiliac joints, and it also happens in the spine, and eventually it causes fusion of the joints. And so we've got this gentleman here, and you can see here that you lose your lordosis there of your lumbar spine, so it becomes just straight, and then you have increased kyphosis of your upper spine. Early symptoms include stiffness, pain, low back pain, and then restricted motion. So of the spine, obviously, because it's fusing. We talked about gout. Remember that gout is high levels of uric acid in the blood and other body fluids. And once the uric acid levels get high enough to crystallize, they start to settle in the joints. And very typically, it's your big toe. That's actually 50% of people with gout. That's where it starts, is in their big toe. So I mean, it's kind of funny. And I told the story of the guy who came in because he was having a gout flare up in his big toe, and then they figured out he's actually also having a heart attack. Okay, patients with gout are at risk for kidney stones because of this uric acid buildup. Okay, sometimes they will get gout in other places. By the way, just half of them are like in the toe, but you can also get it in your ankle, in your knee, wrists. Those are some places that other people get it. So this just shows you how we break down our dietary purine gets broken down into uric acids, which then are excreted through the intestines or through the kidneys. But if they build up, then we have too much uric acid. And so we do have medications that will help this. So causes and risk factors. Remember that the old men are who are at risk, okay? So being male, being of increased age, high intake of alcohol, red meat, and fructose, okay? And also some drugs will affect this. Here's our tophaceous gout there. So you've got your 3 symptoms. That first stage, or your first 3 stages, your first stage is asymptomatic, and all you have is a high level of hyperuricemia. But it hasn't gotten high enough to crystallize yet, so it's not settling in the joints. Then the acute gouty arthritis is where that joint will start to get painful. Okay, it'll start to get red. And then tophaceous gout is actually where it extends beyond the joint and actually starts to erupt through the skin. Okay. So this picture here is just your acute gouty arthritis, where it's swollen there. And then back here, these are tophaceous gout in this picture. So we've got acute signs. They will call it having an attack, okay? So you'll see an attack of gout. And people will get a fever because they will get systemic inflammation, because remember that uric acid is all over. Okay, it's not just in a joint. And so when they're having a gout attack, they will have a fever, they will have elevated leukocytes or white blood cells, and then the joint itself is inflamed as well. We talked about contractures, stress-induced muscle tension, disuse atrophy, and I have a picture possibly. Here we go. I'm going to try to move this picture into what I'm narrating here so you can see this. But there we go. So this was a picture that one of your classmates sent me, and this is her, I can't remember if she said it was her brother or her cousin, but his right arm there you can see is very muscular. His left arm has like nothing, okay, and that was because it was in a sling. So that is disuse atrophy right there for you. Okay, so how do we prevent it? Is with our isometric movements, okay, and passive range of motion. All right, fibromyalgia, we talked about this. We don't really know why it happens, okay? Most times it's women. It seems to happen in your 30s to 40s. It's typically associated with mental health problems like anxiety, depression. It's often treated with antidepressants. It's also treated with complementary alternative medicine, what we call CAM, such as acupuncture and acupressure. We don't really have a strong patho description of it. There are like 3 things that we think could possibly play into it. So with the fibromyalgia, you have these tender points, and you have to be tender, and I think 11 of the 18 in order to be diagnosed. And they just literally just poke on you to see if it's tender. So everybody can start poking on themselves now to see if they're tender in all these places. I took that one out as well. So toxic myopathies. Remember that the most common cause here is alcohol abuse. And you will have acute attacks of muscle weakness and pain. And people who are chronic alcoholics will have chronic muscle weakness. And sometimes the muscle fibers are actually necrosed. And sometimes this can actually be genetic as well. However, typically that would happen as a child. You would see that. So other causes include our statins, which are lipid-lowering agents. It also happens from drugs that we use to treat malaria, steroids, narcotics, but really the most common thing is alcohol. Bone tumors. So we talked a little bit about bone tumors and how the bone tumors have the same characteristics as they do with when we talked about cancer. Okay, so our malignant bone tumors, our cancerous tumors, they have the increased mitotic rate. They have a really big nucleus. They have lots and lots of genetic material in them because they're constantly dividing. So osteosarcoma, we talked about this being predominantly in adolescents and young adults. If it's in older adults, it's probably a secondary tumor from previously having had radiation for some other type of cancer. Most of them occur around the knees, but they also can occur in the shoulder. Then we have our chondrosarcoma that we'll see around the hips, and these are middle-aged adults. This is what happens with middle-aged adults, and it infiltrates the spongy bone. Okay, and you can see here that it just causes these huge masses. And we looked at these in class, so lots of masses there, and if they're way up in the hip like that, we can't amputate that high. So we do radiation as much as we can. You don't need to know the other types of bone tumors. You may see them when you're doing your patient research, okay? The one I wanted to point out is the Rhabdomyosarcoma because it is highly malignant and it does metastasize extremely fast. It can involve the eye, the tongue, the neck, the nose. It can be in your heart, which is really weird, by the way. Very few people will get cancer of the heart. This girl, I found this picture just on Google. Hers was in her the muscles that controlled her eye, and so they actually had to take the eye out as well. Okay, teach these people about patho. I would like you to try to do these on your own, and then I'm going to go through them real quick. Okay, so go ahead and pause and answer them to yourself. Okay, so hopefully you tried to answer these because that's really the best way for you to study for exams. If you're having trouble studying, researching these and coming up with the answer is a really good way. So number one, the doctor said I have a compound fracture in my leg. Does that mean it's infected? I know he's worried about infection. Okay, so remember that compound fractures are what we talked about compound fractures are what we talked about and that we now call open, okay? And so with this, his bone is actually sticking out, which makes sense that it is that he's worried about infection, right? Because any kind of break in our primary line of defense, our first line of defense is our skin. Well, that's one of them anyway. Obviously, something like that is going to be prone to infection. What kind of infection? Osteomyelitis. Okay, because we've got a break in the skin, the bone is directly exposed to the environment and to the pathogens that live on our skin, which everybody has staph on their skin. Okay, Mr. Shea says, when I was 5, I jumped off the roof and broke my left leg. It's much shorter than my right one. My friend broke his leg, and his legs are both the same length. Why? Well, that's because you're still growing when you're 5, okay? And if you break your leg and it breaks through the growth plate, then, it is going to be much shorter because that leg isn't going to necessarily grow anymore. Mr. Tay has osteomyelitis in his lower fibula. He says, how did my leg bone get infected? The only break in my skin is this oozing diabetes sore on my ankle. Yes, that would be how it got infected, the oozing diabetes sore. So remember that anything that is a break in the skin, if it's oozing, then it's probably infected. And we've broken down our primary defenses, and that open wound then can travel into the bone, or the bacteria can migrate into the bone and cause the bone itself to become infected. Mr. Vargas, he says, it's been 3 weeks. I want this leg cast off right now. I have to go back to work. I can't wait another 3 weeks. I'm bored. So remember your different stages of bone repair. Okay, and it's not instantaneous. We have to go through all of those stages before the new bone is as healthy and can withstand the weight. Okay, the cast is on his leg, and so as soon as he stands up, if those bones aren't healed, then that's just going to break one more time. All right, number 5, what makes these ugly lumps on my knuckles? The doctor called them Heparin Nodes, but he was busy writing prescriptions for my hip arthritis, and I didn't ask him. Okay, so Heparin Nodes, remember that those are manifestations of osteoarthritis. And so she does have osteoarthritis, and and what we basically just tell the patients is this is one of the symptoms of it. Anti-inflammatories can sometimes actually make them go down, okay? So a lot of people will take anti-inflammatories for their osteoarthritis, and that will help a lot of those. Mr. Crab is undergoing diagnostic testing for possible osteoarthritis. He says, I understand why I spelled Y wrong, why they do scans to look at my bones, but why are they taking blood to check for bone cancer? Why not look at the bones? And this goes back to our tumor markers. Okay, so remember that if we have bone cancer and it's in the early stages, you may not be able to see it. But remember that we have tumor markers that are released, and bone cancer is one of those things that we can check for. Okay, and so we will look at tumor markers for certain antigens, okay, and that's also um, the the other reason. Sorry, I lost my train of thought there. The other reason is that we can also check for metastasis, okay, because if it's metastasized, then it's much easier to find the tumor markers. There's going to be higher levels of them. Okay, the case studies. So I'm going to ask you again to pause and try to answer these to yourself. Okay, then I will give you a chance to pause here, and then I'm going to answer the questions for you. All right, number 1, Joey. He most likely has a closed fracture of the left femur. So femur fractions are often displaced because of the muscle mass in that muscle. Then spasms after a fracture. So he'll require reduction of the fracture and then immobilization of the bone. And what they will probably do is that ORIF that I talked about in class, open reduction internal fixation, where they'll actually open up the skin, they'll put some kind of screw or metal plate in, or maybe wire, and that will hold the femur together. And then that will help it heal quicker because the bone then is in constant contact with itself. And then the likely therapy, what type of injury? We talked about that. What will the likely therapy be for this injury? It's likely to be some kind of cast, okay, or other immobilizer. There could be an external fixation, something like traction, which you'll learn about in fundamentals. That will be temporary though. So most likely he'll be non-weight bearing, what we call NWB, for a certain amount of time. And then after several weeks, he'll likely be able to do partial weight bearing as long as he's got the full cast on, things like that. And then what processes are necessary for normal healing of the injury? Go back to that diagram where it talks about the hematoma formation and all those 5 stages there. Okay. All right, number 2, Carla. Carla probably has age-related or post-menopausal osteoporosis. So women, when they hit menopause, have estrogen deficiencies, and that estrogen deficiency, along with age, will cause us to start to decrease the percentage or density of our bones. Okay, so a lot of times what we're going to do is what we will see are those pathologic fractures. Okay, and remember that she's got a sedentary lifestyle. She's very thin. She's small in stature. Okay, and so at this point, she's probably going to need medications. Okay, we do have medications, and that's we've really come a long way in the medications because they used to be every day, then they were once a week, and now there's some that you just take once a month for these meds that keep osteoporosis in control. And then she'll probably get on calcium and vitamin D supplements. All right, number 3, Peter. So Peter has osteomyelitis after an open fracture. Okay, and he says that why isn't this cured with antibiotics he's already received? So he probably got antibiotics after surgery because anytime you have an open fracture, they have to go into surgery and reduce it, okay, which is putting it back into place. Because it was an open fracture, he was automatically put on antibiotics because that bone and his insides were automatically exposed to staph and stuff. The problem is that we don't put people on like 6 weeks of IV antibiotics just because they have an open fracture. We do know that they're at risk for osteomyelitis, but it's not so common that we go ahead and treat it. Okay, unfortunately, we can't just say, oh, well, prophylactic antibiotics once or twice. It doesn't work that way. So he actually is going to need like 6 weeks of antibiotic therapy after all. Okay, number 4. Grandma's been diagnosed with osteoarthritis in her hips and knees, and she wants you to explain I want you to explain this to her and tell her what to do so that she can continue her activities of daily living. Okay, so we know that with osteoarthritis, we know that this is a local inflammation of the joints where the cartilage in the synovial joints starts to kind of flake off, and so the bones are actually rubbing straight together. This will often be treated with anti-inflammatories. Okay, stretching and gentle exercising will help. Okay, we typically will recommend mild range of motion with the stretching. They have over-the-counter anti-inflammatories. They actually have prescription anti-inflammatories as well. Eventually, she may need a joint replacement. Okay, so there's lots of things that we can do for arthritis. And number 5, George, he says he has gout. And what do you expect his signs and symptoms to include? Well, 50% of people, it's in their great toe, so tell him to take off his shoes. Okay, ask him where his symptoms are, and remember that at the second stage of gout is that acute gouty arthritis. So you're going to expect him to have redness and swelling and warmth to a joint, probably his great toe. He most likely also has a fever. Okay, because remember that it is a systemic disease as well. If we drew his blood, we would see high uric acid levels. Okay. I'm going to stop there, and then the next narration will be the alterations of musculoskeletal function in children.